and this is adult cancer survivorship. So I will be just talking today overview of the principles of cancer survivorship, just doing a broad overview. And just to say a little bit about myself, I actually, my slides are not advancing. Great. So I actually trained with Dr. Ganschow before training with Dr. Hong over at Cook County in preventive medicine and public health. And so this is a perfect fit, a perfect mold for me, working in cancer prevention, public health, cancer survivorship, and a little personal detail about myself. My sister was diagnosed with breast cancer when she was 45. And I found out that I'm at high risk for cancer as well. So this is definitely a topic that's very close to me, and almost everyone knows someone that is a cancer survivor. So how do we define this term? The NCI and NIH say an individual is considered a cancer survivor from the time of diagnosis, during and immediately after treatment, and through the balance of their life. So once a patient is diagnosed with cancer, they've had that cancer brewing in them. They've already survived it. So considered a cancer survivor from day one. And with advancing treatment, this population is growing. This is a heavily circulated graph of the growth of the projections of the cancer survivor population. And the black line you see is around about 2021, and we can see it's runs out to almost 18 million cancer survivors today. And there are supposed to be over 22 million by 2030. So this is a growing population that really has a lot of significant needs we have to take care of. And as I said, patients are surviving longer and longer. Almost half of patients now are surviving 10 or more years with cancer. So it's no longer, this dismal kind of diagnosis that we had in the past. So survivorship is very important for these patients. It focuses on the health and well-being of a cancer survivor from the time of diagnosis to the end of life, again, incorporating that, including the physical, mental, emotional, social, and financial effects of cancer. So it's very, very holistic approach that incorporates many different areas, many different teams into the care and the taking care of the needs of these cancer survivors. And I want to make a plug because we don't just talk to cancer survivors. We talk to those who are at high risk for cancer as well, a group called cancer previvors. And this term was coined, I found out in 2000 by the executive director of FORCE, which the logo is down in the corner there. These are survivors of a predisposition to cancer who have not had the disease. So patients who are mutation carriers, as cancer predisposition mutations, a strong family history, or another predisposing factor that puts them at an elevated risk. So as I said, these standards of survivorship care apply to all these patients and comprehensively address all the complex needs that these patients have. So these things I'll talk about today include cancer surveillance, screening and risk assessment, monitoring, managing treatment side effects, preventive healthcare and treating comorbidities, care coordination, and providing resources. I'll go through all of these today and talk a little bit about it. So first, going into cancer surveillance, screening, and risk assessment, all of our patients come and talk to us and they're worried. They're always worried. What are the chances that this cancer I had before can come back, right? They're all worried about recurrence, this cancer reappearing. Or can I develop a new cancer in a different place? And these are tricky questions to answer, right? Because fear of recurrence is such a pervasive issue for cancer survivors. There was a large survey, almost 3,000 cancer survivors were surveyed, and almost 80% of them reported feelings of this fear of recurrence. It's one of the most significant emotional challenges that these patients will face. And it's hard to pinpoint for them because you can see all these different cancer types have different rates of recurrence. And those all depend on the stage of the cancer, the aggressiveness of the cancer. So we have trouble telling them this is exactly what will happen. We don't have a crystal ball. So we like to tell them that a lot of different things are involved in recurrence, but whatever the chances, we will follow you very closely. So if cancer does return, we can find it and get you the very best treatment. So what do we do with surveillance for cancer recurrence? Surveillance is actually follow-up for cancer patients, patients who have been diagnosed with cancer. This differs based on the different cancer type. There's a defined time between diagnosis that is recommended. But these are based upon national guidelines from organizations like the National Comprehensive Cancer Network, which I'll give an example later. But really, these are customized and tailored for each institution based on the institutional practice, and then also the patient's scenario and diagnosis as well. So here is an example of endometrial cancer. We've done some work with the gynecologic oncology team on kind of standardizing the surveillance schedule for gynecologic oncology patients. So the NCCN to the left here lists out a particular set of recommendations, and the Society of Gynonc lists out recommendations that are kind of similar. They both say how often to follow up, how often to do cytology, and how often to do labs. So within the institution, we kind of went another step further and took this to another level based on how we practice as a whole. So it's very, very intricate. And again, every cancer, it's different. So we have different guidelines that we follow for each one. In screening for new primary cancers, we want to detect anything that might be going on early. So this includes your run-of-the-mill mammograms, PAPs and HPV screening, colonoscopies or stool cards, and low-dose CT for lung cancer screening for patients with a significant smoking history. Generally, we follow the USPSTF guidelines, but we also really weigh out those risks versus benefits. For each patient, we cater these recommendations to them. So we say, you have metastatic cancer, and it may not be of the most utility to continue doing mammograms, or you're 82 years old. I don't think you need another colonoscopy. So the USPSTF, the U.S. Preventive Services Task Force, is this federally assembled task force that builds evidence-based recommendations on preventive services. And they're the ones who put forth the standards that say, get your colorectal cancer screening at age 50 and things like this. They have these recommendations like this that are graded A, B, C, D, and I, and A's and B's are funded by Medicare. So these are heavily paid attention to in a primary care setting, and our cancer patients don't exactly fit these recommendations. So we do modify them. So again, it is another tailoring these different recommendations to our individual patients so that we have the optimal follow-up for them. In terms of cancer risk assessment, we go into depth with our patients because we want to talk about things like treatment-related second cancers. We know that chemotherapy and radiation can change the mechanics and change the dynamics of the body, and that cancers can develop later on. For example, someone with breast cancer in their 50s may be more susceptible to developing a leukemia in their 70s because things have been altered in their body. We take very thorough family history evaluations to try to identify patients that might qualify for genetic testing, so that genetic information about their cancer risk will be very helpful for them, but also for their family. and the impact of their lifestyle and exposures. We pay close attention to things like diet, physical activity, and as I said, genetic predisposition is important to us. So moving on to how we monitor and manage treatment side effects. And when I'm talking about these side effects, it kind of breaks down into long-term effects versus latent. The long-term side effects are those that arise during the treatment, but they persist over this patient's perhaps lifetime. So something that manifests when they're getting their chemo that just won't go away. And then latent side effects. Cancer is the gift that keeps on giving, because these may not appear until many years after treatment completion. So incredibly frustrating for patients. And I just want to talk about a few of these and kind of a little bit of our approach to them. Each one of these is its own talk, so forgive the limited slide. First of all, cancer-related fatigue. This can really significantly affect quality of life for our patients, and for the patients and also for their families and caretakers. It can be a big problem. It affects lots of our cancer survivors, up to 90%, and a lot, up to 3/4, have advanced disease. A third of the patients will have fatigue symptoms for years and years after their cancer diagnosis. There's chemo-induced peripheral neuropathy. This is common, especially in patients who have had platinum-based chemotherapies, which are used a lot in things like breast cancer and colorectal cancer, to name a couple. It causes this chronic pins and needles, numbness and tingling type feeling for patients that can be really detrimental to their function and cause neurologic dysfunction as well. We do have medications we can try to treat, but a lot of times PT and rehab, or even acupuncture that's targeted at neuropathy, can be helpful as well. There's cancer-associated cognitive dysfunction. So this is the chemo brain all the patients will complain of for at least some time. This, may go on for a short time after diagnosis and treatment, or a long time. And it's actually, we can see this with neuropsychological testing or on different imaging studies, which I was surprised to see. So we use things like cognitive rehab or using some medications. Some patients we have taking Adderall. Exercise and meditation can be very helpful as well to help improve focus for our patients. So getting into some long-term effects here, cardiovascular disease is one that came out of the woodwork. Obviously, more people are at risk of cardiovascular disease with a growing population of survivors. We already are at about 2/3 of our deaths are related to cardiovascular disease. So as that population of survivors gets older in age, we're going to have more problems. And compared to controls, though, patients who are survivors of cancer have 15 times the rate of congestive heart failure, 10 times the rate of cardiovascular disease, and 9 times the rate of stroke. And anthracyclines, this is another type of chemotherapy that also is used in breast cancer treatment and others. These are highly implicated, and we can see heart disease coming on about a decade or more after they've been treated. So we will follow these patients closely with annual echocardiography. There's many psychosocial concerns that these patients have, and we try to pay attention to all of them and address everything. Anxiety and depression is so pervasive. 18 to 25% of survivors at least report anxiety and maybe psychological or physical symptoms. Depression can be also associated to an increased risk of mortality as well. As we said, fear of recurrence is pervasive. There's even a degree of post-traumatic stress or cancer-related stress, which can affect a lot of survivors. Fertility issues and family planning is something that is particularly challenging for patients, as some of the cancer treatments, chemotherapy and radiation to the pelvis can be detrimental to the reproductive system. So it's important and paramount that we provide reassurance to these patients, treat any contributing factors, and provide any support or resources that we're able to. And physically, of course, is the most obvious issues with cancer survivors: chronic pain and weakness, which can be due to the cancer treatment like surgery. It can have phantom pains from removed organs. Chemo can cause mouth sores. Radiation can cause burns and scarring. And there's a lot of issues that come with all of that. Lymphedema that Morgan and Leanna can speak to, which can really inhibit patients' functional status. Pelvic floor dysfunction is another one. We have a robust pelvic physical therapy program here to try to help to retrain that pelvic floor to reduce the incidence of incontinence or pelvic pain. Hormone-related symptoms, obviously, a lot of women will go through menopause when they receive chemotherapy. And then sexual dysfunction is also a pervasive problem for patients with things like prostate cancer can experience this. So moving on to the next section, talking a little bit about preventative healthcare and evaluating and treating comorbidities, which I kind of grouped together because this is where I put my primary care hat on and help to manage the overall health of survivors, because their preventive care may have lapsed while they were receiving cancer treatment. It's not something they paid close attention to, their hypertension, as they were getting, weekly chemotherapy treatments. They may have lost touch with their primary care doctor or don't have a primary care doctor anymore. So we help to regain control of some of these issues for patients, things like hypertension, diabetes, high cholesterol, etc. And we also ensure these patients are really up to date with everything, their routine labs and vaccinations like flu vaccines, shingles vaccines, and things like that. A big sticking point for us is that we encourage all survivors to establish with PCP for routine health care. The oncologist will be seeing them, we'll be seeing them. We would like a PCP to see them as well, because the more touch points we can have to these patients, the more cared for they feel, and the more able they'll be to voice any concerns that they have. It really takes a village, right? The primary care provider is not important just for that contact. They need to help manage chronic conditions, assess physical function and mental health, review medication use, which is particularly important when we have patients who have pain control issues. We work closely with primary care and behavioral health on that. And encouraging healthy behaviors, healthy diet, healthy exercise, quitting smoking, and reducing alcohol intake. So finally, I want to talk a little bit about care coordination and then providing resources, which is something we do. And the care coordination can be monumental. See a survivor at the middle and all the different teams and all the different resources and support groups and everything that's pertinent to cancer survivors' wellness on the outside. And it really takes this whole team to kind of approach. Although these days we look a little bit more like this, right, with our masks on. But survivorship is kind of at the center, and we will do a lot of, as I said, care coordination. We talked about the surveillance and follow-up that we work with oncology specialties to keep track of. Healthcare management with primary care providers to help these patients manage all their chronic health issues. But then there's also referral to non-oncology medical specialties, as well as referral to supportive services And then the external referrals, the resources for cancer support organizations, which we have some great representation here today. Internally, we will refer to things like non-oncology medical specialties, GI, renal, endocrine, etc. All of these different specialties we have sent patients to. We get our patients are able to talk to us. We have good amounts of time with our patients that we're able to speak with them about any issues they might have so that we can send them to the appropriate physician and specialty. And then supportive services, again, are very crucially important. PT, OT, and speech therapy. Behavioral health, we'll lean on a lot. Social work and counseling, as is represented in nutrition, fertility, and others. Neither of these lists are near exhaustive. So we have a lot of different services that we return to. And Dr. Esther Ree, who's previously with UIC and has left us a little while ago too, did some great work putting together this guide on supportive services for cancer care. I'll send it out again with the PowerPoint and the recording for this talk, but it has all the different services, how to get a hold of them, and it's a resource for us as well as the patients. So it's a great document that has been created. And external referrals that we will make are to numerous different organizations, right? And again, not an exhaustive list, but our Young and Survivor program, Talia and Christine, Wellness House, Kelly and Misha, American Cancer Society, Jessica, as well as many other organizations that really provide assistance and support and maybe transportation, maybe wigs and things like that to all of our cancer survivors that are really things that help our patients feel empowered and feel like they can take on each day, because a lot of them feel kind of lousy with this cancer thing going on. So we, Dr. Hong likes to say, we have the smartest patients, and we'd like to give them all the tools so that they can advocate for themselves and take control and take charge of their health. So finally, I just want to sum it up, talking about our future directions as survivorship at UI Health. As Susan said, I'm leading the charge right now, and Dr. Ganshaw will be coming on board to help us continue to expand the survivorship clinical program, to get more providers, get more patients, and expand to different areas of the hospital system once we're able to get back into the clinics. Enhancing the awareness of and use of all of those supportive services, trying to engage and bring in everyone to the conversation is super important. And then continuing this collaboration with oncology groups and primary care, and I should have said, and other institutions, so that we can just create a much more robust program so that overall we can give our patients, these cancer survivors, a real feeling of hope. And hope that they can keep on going and enjoy life, and that we are there to take care of them. And we are right now, the survivorship clinical team, myself and nurse Kristen McCune, who I don't know if I was able to introduce herself at the beginning. So Kristen can say hi after this, because here to refer a patient to us, you can call or text Kristen at whenever during the week. And we are happy to see anyone, whether they receive treatment at UIC or outside of UIC. And that is all I have. Does anyone have questions?
I have to say that you did a fabulous job. I am so proud of both of you. I know that there's a lot, you guys are doing a lot. I can't, the program is going to continue to succeed. The way that we define survivorship is truly holistic and truly unique, and it really takes care of a patient population that needs it most. I think probably more than many other Not to say cancer survivors don't deserve comprehensive holistic care regardless, but it really is unique to have it within a federally qualified healthcare system as a way to address health disparities. And so this is really an important program.
Mhm. It is. And I was very encouraged yesterday as well that the second executive order that President Biden signed was to enhance support for underserved communities to promote health equity.
Yep, absolutely. Things are changing.
Yeah, so very inspirational. So, does anyone have comments or questions? Kristen, do you want to give a shout out to you? You want to say something?
No, just hi everybody. I'm like, Dr. Mann said, I'm the nurse in Survivorship. That number that she has at the end here, it is textable. You can also do an epic message to me with the patient's MRN. Just forward it to me and I can get in touch with the patient and get them scheduled with Debbie. Nice to meet everybody.
And for anyone involved in hospital operations, Kristen really makes the survivorship clinical program work like Mayo.
Mm-hmm. Yeah, she does.
I can't understate how much she works, how hard she works.
It's really incredible how much she gives to this program.